So my name is Joshua New. I'm a policy analyst with the Center for Data Innovation. For those of you who don't know me, there's a couple of familiar faces here. We are a public policy think tank. We study the intersection of data, technology, and public policy, and open data kind of falls right in the middle of that diagram. So we started Open Data Leaders, this meetup group, a little over half a year ago now, and we realized that there was really not any opportunity, or very much opportunity, outside of a one-off hackathon or health data palooza or things like that, for the people making and managing and responsible for government data to be in the same room and have direct lines of communication with people using the data. You guys, the entrepreneurs, other people in government, the contractors. So we really wanted to establish a regular meeting that you could have direct lines of communication. And we are very happy this month to have our second part series with HHS. Last month we had David Portnoy, who was running the new demand-driven open data program on how we prioritize the release of data sets based on value case. And now we're very lucky to have Damon Davis, who's in charge of the Health Data Initiative. He's going to be talking about that, the relaunch of healthdata.gov, and we're very lucky to have him. And just so you can mark your calendars, next month on June 25th, Thursday, we will have Beth Beck and Deborah Diaz from NASA. They're going to be talking about their the Space Apps Challenge, some other open data work going on. That should be very exciting. So feel free to help yourself with some food. You can leave a business card in the back in the fishbowl. We'll sign you up for a newsletter, which is very exciting. I write it every Sunday. And great. So Damon's going to talk for about 30 minutes or so, and then there'll be some questions, but he has a family obligation later, so we won't be able to stay until 8, but feel free to stay 8 until the end, talk, mingle, ask questions. It's great. Take it away.
All right. Thanks a lot, Jeff. Appreciate it, man. Thank you guys very much for coming. Good to see you. I see some familiar faces and some new folks, so great to see and meet everybody. Once again, I'm Damon Davis. I work in the HHS Idea Lab, and we are typically known as the CTO's office, the Chief Technology Officer's office, but we have rebranded ourselves to be the Idea Lab, and I'll tell you a little bit more about that later. So I run healthdata.gov, our website for public access to open data sets that we make available out of HHS. And I'm going to tell you a little bit about our Health Data Initiative and a little bit about the Idea Lab and the innovations that we try to inspire at HHS by virtue of our work. So I think many of you are probably familiar with a lot of what I'm going to open with. Clearly, we are living in a data-driven age. We are living in a society that has, in America, a $2.8 trillion healthcare industry. It is massive, and it is in need of a lot of change, a lot of innovation, and a lot of creative minds like yours to really inspire and drive some of those changes. And just to sort of highlight some of the things that data are already changing, you can already sort of recognize that payment reform, one of the huge things out of HHS, we're trying to pay for quality of healthcare versus the volume of healthcare that we receive. We're also very much interested in the ways that personal interactions with health and healthcare are affecting the healthcare system. How is it that we who are personally tracking ourselves with Fitbits and apps and things on our phones are going to be able to contribute that data back in some form or fashion, be it for our own benefit or for the benefit of others like us? And then obviously data at the point of clinical care, one of the things that we want most is for our healthcare providers to have the most and best information about us, and a data-driven approach to care is going to be the best way forward. So at the department, one of the things that we've been trying very hard to do for several years is change the default setting for our data from closed to open. We recognize that there are so many innovative minds out there, creative people who have a real sort of juices flowing as to what they see are problems in our healthcare system, that they need data sets that we have to really create some of the innovations that they're inspired to do. So we've really been working hard to make open data one of the true functions that is a repeatable process at the department, and I'm going to tell you a little bit about what that looks like. But I also want to just make sure to set the stage for you as we think about HHS as an agency, because it's a lot bigger than we often remember. It's, CDC, Centers for Disease Control and Prevention, has its own massive identity, the National Institutes of Health. FDA, Food and Drug Administration. All of these agencies are in the HHS family, and even some that you may not be as familiar with. For example, the Administration on Community Living. They focus on handicapped populations or disabled populations, the elderly among us, and others who are sort of in need of social services in this special consideration and connectivity. SAMHSA, our Substance and Mental Health Services Administration, Administration for Children and Families, which likes to say that they are the human in health and human services. So they do a lot of the social services delivery. But as you drill into any one of these organizations, you will also then see that that organization has a ton of organizations underneath of it. So you can imagine that having open data be something that is a default setting at the department is incredibly challenging to actually make happen, but we're making great strides in that. So you can see here in the National Institutes of Health, there are approximately 17 different centers, and among that one center, you're going to have a whole bunch of other centers. So what we've tried to offer is a platform or a place where the data sets can live so that the public can find them. That public website is healthdata.gov. This is its current representation. It's actually going through a process of being redesigned right now. So we're going to launch a very, very simplified version in the very near future. But as you can see, you can access data, blogs, and information and all kinds of stuff through this platform. And it really is an opportunity for you to gain access to what are, in many cases, free data sets. They are not things that you're going to have to necessarily pay to download. There are going to be some instances where you're going to have to apply to gain research access to some data, but there are actually some really exciting announcements coming out that will be highlighted at the upcoming Health Data Palooza, where you will not necessarily need to provide research-specific access applications to access data in the future. So stay tuned for some of those announcements. To allude to a couple of the things that are being liberated, and I just want to show you some of the data sets that are available and a couple of examples of how those are being used. So one of the agencies that I've already talked about, the Centers for Medicare and Medicaid Services in the HHS family, is really trying to utilize data to spur health system innovation. And they've got a couple of different things that they offer. They offer a data navigator, which is a similar site to healthdata.gov, but it's a place where you can go and find specific CMS data sets. The data navigator actually federates to healthdata.gov, so anything that's on the data navigator you will also be able to find on healthdata.gov. They offer a lot of quality indicators about different parts of the healthcare system. So you can find hospital compare data, nursing home compare data. So they're starting to show provider quality care data. So there's a lot of really interesting ways that you can start to look at the healthcare system as a continuum of where quality is, where it maybe could be improved, and start to infuse some of your really interesting ideas as to where there could be opportunities to improve the quality in those areas. They also offer what they call a virtual research data center. So in a previous model of accessing CMS data, what you had to do was you would have to apply, prove the reasons that you are interested in accessing the CMS data. They would then validate your use case, and go over and take a cut of the data, put it on a hard drive, ship it off to you, and then, who knows how many days later you've now got access to your data, which is a point in time from when they cut it and is therefore probably out of date and not necessarily anywhere near what you would hope to be as real time. So the virtual research data center is actually offering people an opportunity to basically buy a seat at the table where you can now come into a data enclave that they've set up, and you can access a lot of identifiable data in closer to real time with tools and all kinds of resources in the data center that are going to allow you to do some of the mashups that you're interested in doing. So you can't take the data out, but you can gain quicker, much more cost-effective access to the data. So the virtual research data center is something that they're very focused on promoting. Excuse me. A use of CMS data is an organization called AIDEN, and we've been talking about these folks for a while, but it's a really interesting story. AIDEN is basically a company that has taken some of the CMS quality data and said, if you are going to be discharged from the hospital and we're going to refer you to another healthcare provider, we would love for you to have the best quality care provider locally appropriate for your home or wherever it is that you're seeking care. So AIDEN has taken quality indicators from CMS's data and they have paired it up with the various healthcare providers that are out there in your local area, so that when you are now being discharged from a hospital, instead of sliding you a piece of paper with a whole bunch of random healthcare providers on it, they're actually sliding you a new piece of paper that has quality healthcare providers that are in your own geographic area. And by virtue of giving you those specific healthcare providers as recommendations of who to follow up on, you're now probably less likely to be readmitted into the hospital because you are following up with a specialist who is providing higher quality care. So they're introducing an opportunity for the consumer base to be contributory toward decisions that are based on quality versus volume. Excuse me. OpenFDA is another really interesting example. Many of you are probably familiar with OpenFDA or not? Or you, show of hands, familiar? Many of you guys are in the back. So OpenFDA is another interesting one where you probably are familiar with FDA as a regulatory body. And therefore, they're very challenged to release data for a variety of reasons. But what they realized was they were getting a lot of FOIA requests, Freedom of Information Act. And basically the public has the opportunity to request all kinds of data from the government by way of this Freedom of Information Act, which we refer to as FOIA. They realized that some of the things that they were receiving requests for were medical adverse events, recalls, reports, and other things. And so what they decided to do was, instead of repeatedly processing those same requests over and over again, let's just make that data open. And let's make it open through APIs and other kinds of access points. So OpenFDA is a new initiative out of the Food and Drug Administration. It's been alive for about a year now, actually. But it's a really great opportunity to gain API access into some data sets that were never previously available, let alone available in an API that you can constantly be accessing. And they're building out OpenFDA into bigger and larger volumes of different kinds of data. So, you know, prescription drug and over-the-counter drug biologic product labeling is a third one here, but that's only 3 of the many that they're going to be producing. So they've got some exciting things happening there. Now this is an interesting use case for the Food and Drug Administration data because Pillbox is actually not an external private sector company. Pillbox is out of NLM, the National Library of Medicine, under the National Institutes of Health. And so what Pillbox has done is they've taken these APIs and all of this access to these Food and Drug Administration data, and they've said, among those things, what we need to know are a pairing or a matchup of the pills that are available across the board with the descriptions of those pills. And what Pillbox is doing is they're actually providing a platform upon which you can find images and data about thousands and thousands and thousands of pills. But they are a NIH entity. So I just wanted to point out for you that it's not always the external innovator that is coming up with some creative use case for the data. There are often times when the HHS departments are using their own data, and I could cite several other examples of it. But this one I thought was particularly interesting for that internal use case. So in this Pillbox example, a lot of times the access to the data is external, but I've also heard that the Veterans Administration is considering the utilization of this identification of pills, and there are other folks like, what's our main online site for when you Google, I can't think of the name, at any rate, there's a major site that we all basically reference for our questions about our own health.
WebMD.
And they are also considering how they could use Pillbox. Thank you guys for the save. So I just want to give you 2 quick examples of what it is that can be used for the data. I would love, when we get to question and answer and more discussion, to hear about some of your own use cases for the data, because I think it's really inspiring to be able to take those stories back. The thing that I think the public undervalues about sort of sharing back your stories of how you're using the data is these are not well-funded mandates for us to make these data open. So we have to take back the use cases, because that actually ends up being the fuel for how we can convince other people who don't have open data to make their data open. And it also helps us to say, see, we told you there was a reason you can make this data open and it will be used for something. So if we're able to take back those examples it ends up being a lot of fuel for allowing other data across the department to be made openly available. So I encourage you always to share your data stories of how you're taking HHS or even other government agency data and tell them how you're using it. Show them how you're being creative with it, and they then will take that story internally and say, you'll never believe what I just heard last night. I want to tell you the story of how somebody's using our open data to do X. And it can be really inspiring for a lot of people across the department. I wanted to then turn to the Idea Lab. I've already told you that we've rebranded ourselves from the CTO's office to be the Idea Lab. And I want to make sure that you have a better understanding of sort of what that means and understand what innovation looks like within HHS. So what we're trying to do is cultivate innovation for a more modern and effective government. And I'll tell you a couple of ways that we're trying to do that. But the basic idea is HHS is a massive entity. It's got probably 90,000 people or something ridiculous like that. And you can imagine that many of those people who've been there for decades have been doing the same or similar jobs for many, many years. And they know how to do that job really well, but they also have a great idea of how to do that job much, much better. But the problem is, how do you get that one person who's down at the line level, who's been doing that job for so long, to be able to raise their hand and say, I got a great idea for how to do this better, and I think it would save money, it would lend efficiency, what have you. So we set up what we've sort of loosely referred to as some pathways for innovation, ways to excite and ignite some of the different ideas and really give people a safe place to test out some of those ideas. And what we have here are a couple of different innovation pathways. I'll hit on a couple, but I'm going to touch on one specifically in a moment. The HHS Ignite Accelerator is basically an internal, small incubator where we're trying to offer people an opportunity to just think through what it is that the problem that they're actually trying to solve, who are the real customers, and is this a viable use case, something that can be proliferated throughout their own organization, let alone into the rest of HHS. So this is a very small, short-term, low-money Ignite fund. But basically what ends up happening in this particular innovation pathway is that people come and we started to offer money in terms of we were thinking that people would want to do software solutions and things like that. But really what they needed was a place to discuss what it was that they wanted to accomplish, a way to sort of explore where the pathway forward is, and some of the tools to create sort of a more innovative thinking process. How do I do agile and lean and some of the other things that many of us might be familiar with, but some of those folks might not. The Ventures Fund is a longer term, larger dollar amount, sort of higher level version of the internal incubator. And the HHS Innovates Awards program is basically a way to sort of retroactively celebrate some of the innovations that we've proliferated throughout the department. I want to highlight the HHS Entrepreneurs and Residents program because that is one that the gentleman who was here last time to present, David Portnoy, is a member of the HHS Entrepreneurs and Residents cohort that we have right now. And basically what we're trying to do in these Entrepreneur and Residents programs is recruit external talent to help us solve problems that we've identified internally. So the problem that I'm going to highlight for you first before I go into David's project was one that was actually kind of interesting. I hadn't really contemplated it until this came up. But our organ donation and transplantation system in America is something that you would hope would be extremely, extremely efficient for obvious reasons. These are very important organs that their lives are depending on receiving the right thing at the right time in a timely fashion. And if there's any problems in that, you can imagine that there can be some very hard consequences for inefficiencies in the system. Unfortunately, there have been a few inefficiencies in the system. And so what we decided to do was put out an Entrepreneur in Residence call. Lo and behold, the individual who responded to this particular call for an Entrepreneur in Residence came from a logistics leader that is globally known, the United Parcel Service. So you could see how by inviting external expertise into an internal problem, you are now creating a partnership with the public in terms of solving some of these critical problems and issues. So I just wanted to sort of highlight that one. That is one of many that we could highlight. And you can find all of these different innovation pathways on hhs.gov/idealab. And you can parse through all of these different stories. I'm going to just drive a little bit deeper into this particular one, demand-driven open data, which, as I said, was presented recently by David Portnoy. His email address is right here, david.portnoy@hhs.gov. But the basic premise of what David is trying to accomplish is the following. We've already talked about how open data is really inspiring and fueling innovation, but one of the challenges that we have inside the department is knowing what people want and actually providing that thing back to them. So the bi-directional conversation, the pulling sort of a signal from the noise of what we think people want from data versus actually hearing the voice of the individuals who want that specific data. So what David has been trying to do is create more of a demand-driven approach to open data at HHS. And I'm going to tell you just a little bit about it. He's developed what for right now is a GitHub platform where he is trying to accumulate a bunch of different use cases. He's taken ideas from people like you who have said, I need this data from this agency in the following way, and he's now gone inside the department to say, I just heard that this person needs this data from your agency in the following way. So then the idea is to hopefully turn around that data set in the closest form of what a person has asked for and say, here's what you were looking for. Because our biggest challenge, I think, in the open data space is next to sort of getting more and more of our colleagues to engage with open data is to actually have them have a guided approach to, and know what it is that they want to produce. So basically, we're taking input from users. We're trying to evaluate what it is that someone has asked for on a cost, savings, and risk basis. We're doing sort of the internal strategic factors. What does it mean to release this data? How does this data, if it goes out there and is put next to this other set of data, what does that mean for re-identification of certain populations? What does it mean for any part of our strategic view? Any of those sort of internal factors, well, then I'm going to prioritize those use cases, and this is when this is built out into a larger volume of use cases, and then try to implement the policies that are going to allow that data to be released to the public in the form and fashion that they've asked for it. So this is sort of a high-level schematic of what it is that we hope will be accomplished with demand-driven open data. But really what we're trying to get to is a systematic, organized, transparent approach to open data that we've never had before. David's pretty excited about it. I think he's having fun because one of the great things about being in the Idea Lab is we get to interact with so many different parts of HHS. You get so many interesting stories of what people are working on, what data they have, what kinds of programs, research, activities they're engaged in, that it can be really fun to actually go out and have these conversations about what kind of data people are interested in. I wanted to also highlight for you guys that there's a much larger data conversation that is going to be happening actually in 2 days. The Health Data Palooza is going to start, well, maybe it's 3 days. Sunday, May 31st. It's here in DC. The Health Data Palooza is a massive event where basically folks are talking about all of the different ways that data can be utilized. It's everything from geolocation data to how it is that you can mash up the data on different platforms. What does it look like to exchange clinical data for the benefit of patients? All kinds of conversations in the healthcare space about the utilization of data. I run a recurring session there called the Data Lab. And the Data Lab is actually a really fun thing for me to put on because I get to do that little piece that I did before where I talk about the agency that's using the data, that produces the data, and then the innovator that has taken that data and provided some alternative use for it. So I have a whole bunch of pairings where the data owner will come and present the data that they have, and then the innovator will come and say that data is valuable to me because. So it's a fun session, but that is one of many different things that are going to be happening at the Health Data Palooza. So I would encourage you to go to healthdatapalooza.org, register, be part of the conversation, share how it is that you're using data, and the different ways that you would like to see the data be contributed back to you. So I'm going to cut it here because I want to hear the questions and have the conversation and all of that good stuff. I hope I haven't talked you to death, but I would encourage you also to stay in touch with the Idea Lab. We've got a lot of really interesting and fun things happening. We actually just announced today that we've got a new Chief Technology Officer. So Susanna Fox has joined us at the HHS Idea Lab. We're really excited to have her. And I'm happy to take any of your questions, comments, or concerns right now. So thank you guys very much for your time. Go ahead, we'll start with the lady in the polka dots.
But I can offer a user case, and also I want to get some tips from you.
Sure.
And we try to push for some more data from CMS. I'm a policy analyst at the Association of American Medical Colleges. So we download the quality data quarterly, and all the other related pieces, part of it from the regular CMS rule cycle, and also piece of that data, and some of that from the quality, the hospital comparison. So we recently developed a model. So we have roughly 400 teaching hospitals, and they all trying to do a lot of work to improve their quality, whether it's reduce infection rate or and reduce readmission rate. But the problem is currently there are roughly more than 30 measures going on, and when you are given 30 measures, where do I start?
Yeah.
And how should I set the target for each measure? You cannot just say the team, okay, go as better as you can.
Yeah.
And also, a lot of the quality measure is not about how you are doing compared to yourself. It's how are you doing compared to everyone else. I know how I'm doing. I don't know what others are doing. So then we build a model, basically, currently the data released from the hospital comparative, there is measure data, how we are doing infection rate, readmission rate to the quality folks. And then there is the finance data saying, oh, you will get penalized for 1% of your payment to the reimbursement director. How these two pieces put together, there are a lot of steps in between, and there are pieces of information here and there, but not really put them into one place and explain in a very clear way, step by step, how this works. So we're build a model just doing that. Basically three different reports, just to show each program, value-based purchasing, hospital readmission, and the hospital acquired condition. These three reports, step by step, show you the calculation. So if you got infection rate here, which means you ranking through the national level, and here you got a point, and how that point end up turn to a payment adjustment. So we have set up a user group, and there was more than 50 people from 40-some member hospital volunteered to be part of the user group. They include both the quality side from chief quality officer or to the analytical folks, to the reimbursement side, which includes CFO, reimbursement director. We got a lot of feedback. I think their comments are, first they can help me to see, how am I doing? Should I just focus on this area? I can get a big improvement, and then I can go to the next. So set priority, and also how much I need to improve to really see outcome.
So let me just jump in real quick. Are you offering up a use case for demand-driven open data, or I'm trying to understand, like, your product sounds awesome. I'm just trying to figure out what
We are
you have a
currently
question.
only offer to our members. We're still in development phase first. So we basically send out some draft and then collect feedback, and then we're working from there.
So do you need data in a specific way?
Yeah.
Okay, that's what I was trying to get to.
That's why I needed tips from you. So the current data release, they have a lot of information, but not really linked, not synchronized. Because if you want to put the whole thing in a chain, they have to match the time period. For example, the performance period of the measure have to match the payment adjustment. Otherwise, they just won't work.
Right.
We want the calculation to flow. Currently, just missing this piece, that piece. So today I just drafted a letter. Want to use as part of the rule comments letter, just to point out the individual gaps, mismatches we need to make the model really work. Actually, we had a couple conversations with CMS folks. They are all really nice, but they also help me understand that actually just to ask a couple more digits of certain data. Actually, it's not as simple as I thought.
Nope.
So for one individual measure, from measure to payment, there maybe have 3 teams work on each individual component, and then they may contract out with contractor. So even to add more digits, basically they have to change the contract.
Yeah, I understand.
So,
So let me I want to hear more comments as well, but I was hoping to make this larger. If you go to ddod.us, this is the place where you can submit your use cases.
what do you mean submit use case?
So there's just plenty of information there on basically what it is that DDOD is trying to accomplish, how you can do it, and the means by which to submit a use case. David has laid it out very nicely. So right here, ddod.us is the place to go. It's an online wiki connected to GitHub, and basically he is parsing through the various requests and farming them out to the various
So
entities.
what's the turnaround time? What the process?
It's hard to say. I mean, because you already know that this is challenging. You've already said CMS has to do this, and this, but at least your request is somewhere documented. And while this is not a formal process yet, this is what we're trying to get to, so I would encourage you to engage there.
So what will happen if I submit something through here?
We're going to talk to CMS the same way that you have. There will be, other people can comment on your request for this kind of data and say, yeah, we need this too. And that additional participation by others is also going to be a signal that this is something that maybe should be prioritized above other things.
Okay.
So we're trying to build out how this process should work. So we're always encouraging folks to submit their use cases. Yes,
So,
go ahead.
so in effect, if only one party requests it, the chances are it'd be pushed back, or?
Not
will you-
necessarily.
Okay.
No, because this is still an early stage. We're experimenting on this,
Okay.
both from the internal
I
process
know
of
you just
liberating
said
the
that, but I
data.
just wanted to affirm that that's what you're saying,
Yes,
that,
that's correct.
yeah, okay.
So as this, when this becomes a more permanent process,
Right.
it's our expectation that there will be more than just one person who needs a
Right,
specific data, a
exactly.
specific kind of way.
But I'm just throwing that out just
Yeah,
to confirm.
but that can be a portion of how it's prioritized, as much the actual demand
Yeah.
as it is for the level of effort internally, the level
Right.
of cost, what
Right.
have you. So there'll be a variety of factors that play into it. There are other questions or comments? Go ahead, sir.
It's hard to, I mean, that's an excellent case. I'm interested in the volume that you, of data that you take in and what your storage capabilities are for that. And how do you have a time to expire on your data, or how do you, and does your budget cover that? And that's pretty straightforward. And the second one is that relationship that you drew above and beyond HHS, like you mentioned geospatial. And so are you taking that as it comes, or are you actually exploring the interrelationship between inside and outside of HHS, and how things can be brought to bear, like HHS and FEMA and that kind of thing?
So can you just elaborate? I'm not sure I understood your second question. When you said I pointed out, I made a high
Well,
level
you
picture.
made a comment when you were talking that there was a need or an effort to actually marry up some spatial locating data with some of the questions that were being generated, or some of the data that was being generated, how those were complementary. One helped support the other, or at least make it more timely for the users to have, to get it where they need to be. Concerning the area that they needed it from. And you didn't go into detail whether we were talking about a endemic somewhere or something else, but I mean, I can see the relationship, and HHS already tracks things like, CDC already tracks things like that. And is there a already developed partnership with areas that are outside of HHS, whether it's the geospatial folks or it's something else?
Yeah, so I'll start with the second question first. There are a ton of those relationships, tons and tons and tons. I'm actually, one of the things I love about my job is that almost every single day I discover some new relationship between departments, between agencies in the department.
And are they codified, or are they personality driven?
I would say that I don't know. I started to make a guess, but I realized I probably shouldn't speak out of school. I don't know that. And I think a lot of it is demand-driven itself. The fact that sometimes a department will realize they have a need for something and begin the process of procuring that data, so serving up the survey or what have you, and some smart person will say, you know, you can get that over there with Department of Agriculture, with the VA, with blah, 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 right? So there are a lot of those sort of internal demand-driven relationships, and one of the things that you're seeing from the government, or we'll see soon, is there are some initiatives to help us understand, one, just generally where does all of our data live. So Project Open Data basically says, open up every single data that you can possibly get your hands on in an efficient manner to the extent that it's, you know, effective use of your time. And then by virtue of going through that process of finding all of it to open it up, you then will have a better understanding of what's in your, what they call an enterprise data inventory. Once you have that, you can then start to see all of the interrelationships of where you've already got pockets of data that are potentially repeated or absent in one place but present in another. You can really start to think through the linkages. But there's also things on the sort of more administrative data side where you go to Department of Agriculture and you apply for something, you go to Department of Health and Human Services and you apply for something, and the form has basically all the same stuff except for the reason that you're applying. So how can we start to manage the administrative relationships between our data as well? So the government is really working hard to try to have a better understanding of and relationship with the data that we have, we collect and curate, so that we can have some of those better efficiencies that I think you're sort of alluding to. And,
Yes.
and then the first part of your question, back to sort of budgets and storage and things along those lines. Those tend to be in a operating division level. So NIH has its budget for stuff, and every center within NIH has its budget for those same things. FDA, et cetera, they determine their own storage capabilities, their own, you name it, whatever the logistics are for the data's management is something that is established at an operating division level, which is part of the reason why we established healthdata.gov, so that at the HHS level, you would have a place where you could easily aggregate and see what is in the catalog at HHS. And basically, I mean, it really is a catalog library of where you're going to go next to find some data resources.
So
One of
you're
the
not
things-
actually taking control of the data and then serving it from your servers, you're simply kind of an enabler.
We're an
And go to
enabler. Yes.
Okay.
And so it's an interesting thing, because what you end up doing is sort of encouraging one office to follow the lead of one that may be slightly ahead of them. You can point to examples. There are still places in the department where folks don't feel quite comfortable with the data going out in certain formats or what have you. And if you have a place where you can point to someone like CMS, who has tons of identifiable personal information about many Americans who are covered by Medicare and Medicaid, but they have found the ways to de-identify that data, perturbed data sets with small, populations and things like that, such that they can create something that is available as a public use file. And you could point to that as an example of how it can be done. It then opens the mind of so many other people who could say, well, let's explore how it is that we might be able to do that for our own data sets. So it's really empowering for others to see that they're not the first ones to dip their toe in the water, and it can be encouraging for them as well, I think.
Yeah, that was my next question.
Sure.
To what extent does privacy implications affect your ability to make data open?
Mm-hmm.
I mean, to some extent, as you stated, it's anonymous, of course,
Mhm.
based on how you present it.
Mm-hmm.
However, to what extent would Sarah's name not appear, or, Sarah's name have to appear
Mhm.
in order to make data, reliable?
So there's two scenarios there. One, to go back to the CMS Virtual Research Data Center,
Yes.
if you've now bought access to the Virtual Research Data Center, you have purchased access to data and information inside the Research Data Center.
Right.
You can go in there and do all of the mashups and things that you need,
Right.
but you can't pull that data out. The data
Right.
lives there, it's locked down.
So
And there are
Sarah's name
tools
is
in
not
there.
on it, right?
Sarah's name may be on it,
Right.
But the idea is that you have signed the agreements that basically say, I'm not in
Private.
here to try to identify people,
Right,
I'm here
right.
to try to do good things.
Correct.
So I won't go, like, I don't know the details of and the legalities, but the basic
Right.
premise is you can go in there, you can get some identifiable data for purposes of matching it up for other things in order
Right.
to create findings. But on the flip side, they do a lot of work to take some similar data sets, and instead of calling her Sarah, she will be called Jane, and she will be in a slightly
Also
different
the
part of the
gender.
age group. She will be in this adjacent zip code and things like that. So
Right.
there's ways that the folks who, and they're way smarter than me, are perturbing this data to make it very similar and not make it unusable for you to do your own mashups and creative things on. And a lot of times that's purely for the purpose of you sort of being able to experiment on something that looks a lot like a real data set, so that when you get your hands on a real data set in your own community or what have you, you have had the opportunity to sort of play with your algorithms and things like that and really test them out on something similar.
Because I know a lot of the work that you have is medical information, so I could only think that it would be covered under, Privacy Act.
Yeah, there's certain things
Yeah.
that are covered under
Privacy.
HIPAA and Privacy Act and things along
Yeah.
those lines. But there are, we also then obviously have to be very careful in thinking about when you release data that's over here, and nobody ever thought this data over here is going to come out. What are then the potential implications of, mosaic effects of
And
saying?
insurance companies.
Yeah, I mean, you can name, 100 different scenarios for why somebody would want to re-identify folks. If I need people who are over 65 and have a certain condition so that I can market to them for a specific drug, that's a reason to try to re-identify people. But, the vast majority of folks are utilizing data for virtuous reasons. And so we try to maintain the data sets that are going to allow those people to
But
continue
are
to do
there
the great
times-
things that they do. But we do have to be conscious of the fact that not everybody is as,
Are there times when you do use Sarah's?
If you're
I doubt, no.
No, you don't. Okay.
No, I mean,
That's what
because
I'm
that's
trying
the government,
That's what I'm trying to get at, yeah.
no.
You have to.
Okay.
The government is in the business of protecting the public that we serve.
Privacy, right, exactly. Okay.
Sorry, do you want on this comment?
Just a quick comment in
Yeah,
response
please
to
go
that
ahead.
part of that.
Yeah.
Working at NCI and looking at cancer genomics data that comes in, possibly associated with Sarah, there may be a time a year or two from now that we see indications that Sarah really needs to know about the possibility of her developing breast cancer soon. And so there were significant debates about whether or not we should be able to unmunch the data, to be able to find Sarah again.
Yeah.
should we need to do so.
Yeah, that's a really interesting question. I will admit I don't know a whole lot about that, but that's a fascinating thing. If the government has information that would suggest that you've got potential for a condition, what is the obligation? I've not heard that discussion at all, and I can't speak to it in any way, but it's a fascinating question. But it also then sort of begs the question, like, the government's not necessarily your medical provider, so if we're all moving towards quality, I would hope that the medical community would arrive at something along those lines before. And
So it's very much a
To be
debate
beneficial.
driven by good intentions.
I'm quite sure. I'll leave it to smart people like you to figure that out for us, sir.
Comment regarding the same thing. You might want to look into blockchain.
Yeah.
I work with classified data, and we've been able to break down the information and use blockchain so that it's naturally encrypted in a functional way. So you can only decrypt as you're utilizing the information, and it's all compacted, so you can't derive from it.
Yeah.
You have to make systems of systems work together, so then you can actually utilize it like to that fashion.
Yeah.
But that's the future of data isn't, what it means or how it's formatted. It's how it's utilized and how it needs to be.
Yeah.
That way people are actually providing keys as to how they plan to use it. And it gets encrypted under that pretense so that the person can leverage it without actually knowing all the tied information regarding other effects.
And also it allows you a little bit of provenance to understand where that data came from, even though you don't have the entirety.
Each
So
individual can actually have as their you know, encrypting their own data with their own service providers or whatnot. You know, whenever there's an alert of some sort, you know, something like a danger to a certain type of population or whatnot, those people can then decrypt that information to then find out who it's affected by, instead of a provider actually determine whether they get to find out or not.
Yeah, it's fascinating. So I don't know how much folks know about Bitcoin. I am by no means an expert in it, but Bitcoin is based on blockchain technology. And it was so funny, I admitted on a Friday afternoon to our former CTO, Brian Sivat, that I didn't understand Bitcoin. And I had no clue what blockchain was. And after he got through, he said, dude, you gotta just go on YouTube, watch a 15-minute video and just like get the basics of it. And once you do, you'll understand that blockchain technology actually has serious implications for things like healthcare and financial data because of its ability to break down and secure and sort of de-identify all kinds of bits of information, and you can only re-identify the stuff that you have a key for, and no one person can have all the keys. I'm giving you the like super elementary kindergarten version of it, but you can see how something like that could be so impactful for the transmission of health data, regardless of whether it's from government or other places. I think that's a really exciting development that I'd like to see realized in healthcare. Sir, go ahead.
You know, I was at another event earlier today, in law enforcement IT day, and there, you know, we had DHS and Department of Justice and state, and they were all pretty much talking about data themselves. And there are a couple of things I want to ask you. There is a little organization that has been formed essentially, I think it's isc.gov, essentially to be able to provide data to those who need it. Is there any collaboration between this agency and that organization?
I don't know that there is. Can you say more about IAC?
You know, I will email you, I'll
Sure.
talk to you more, because I just walked out of the meeting, I gathered some information. So I found out about it myself today only. So,
Okay, cool.
let me read through it and then I'll point you in that direction.
Great. Last comment, please.
Actually, there was a quick question regarding data, because with blockchain and the way that we want to kind of leverage and predict and forecast all kind of effects, I'm curious as though how much of the data that's being provided is system derived versus, you know, surveys, people derived?
Most of it is survey, people derived data. So, and keep in mind, open data is new for how old all of our data is. We've been doing surveys for 50-something years, right? Only recently did many of them, and I say recent in relative terms, did many of them even sort of come available online in their PDF form, let alone be actual data tables that you can gain access to. So I think there's still a lot of advancements that need to be made. We've put some data resources out, query tools and things like that, but smart people like you are saying, I need access to the real data. So my point in raising those particular issues is that I think there's still a long way to go for many different departments in terms of making their data available. I wanted to underscore that much of it is in fact human created, because some of it is from surveys, some of it is from different programmatic initiatives. We have state level grants where we give out money to the state, and the state administers the program, and we ask for some data back in some form or fashion. And you can imagine that if you farmed out 50 different grants to different states, you're going to get different levels of data quality, timeliness of submissions and things along those lines. There's all kinds of variables that get reintroduced. So, those are some of the things that we're trying to work through, is how is it that you can create, the platforms that will force better quality and timeliness. And so we've made a lot of advances. There's still a long way to go. I think it's a really exciting time because there's so many people using the data for so many interesting things, like what the lady here has said, that the opportunities then continue to present themselves. Because if you see, if I can do this, then what if I did that? That would be so cool. And when you think about the millions of people that are now covered by the ACA. You've got that many more people that are coming in and getting proper health care, which I don't mean to diminish anybody to a data point, but it's actually an interesting thing. You've now got many more minorities, Medicaid populations, things along those lines that have never had real and proper health care before, that is documented in an electronic health record, that is matched up with some form of federal data that says, you, sir or ma'am, are in this age group, in this demographic population, in this socioeconomic status, blah, blah, blah. Here are your likelihoods for these following, you name the comorbidities or what have you. So it's such an interesting time because of all of the technology and the data that is flowing. I think we're all sort of trying to figure out how we fit into the mix. But once there starts to be a lot more connectivity between some of these interesting ideas and data systems, healthcare is going to be a completely different place than it even was probably last year. So it's a really exciting time, and I hope that you guys are excited for it too. Thank you guys. Take care.